My name is Jack Batten, and I'm the Speakers Director of the William F. Buckley Jr. Program here at Yale. It is my distinct pleasure to welcome you all to this afternoon's debate between Mr. Matt Vallière and Dr. Megan Wright on the policy of assisted suicide. Our over 750 Buckley Fellows hold a wide range of political beliefs, but they all stand united against the formation of a liberal-only echo chamber on campus. By providing Yale students with a forum to engage meaningfully with serious conservative thought, the Buckley program has become an institution on Yale's campus and a symbol for a more representative political atmosphere. Especially at a university, where the mission is the cultivation and creation of new knowledge, Buckley Fellows believe that all perspectives must be heard and examined in good faith. You can learn more about the program and how to become a fellow on our website at buckleyinstitute.com. I also want to emphasize the Buckley program's commitment to freedom of speech. Disruption of an event is not consistent with Yale's policies on free expression, as outlined in the Woodward Report. I would ask that each of you respect the right of our speakers to be heard and the right of your fellow audience members to listen to the event. Thank you for joining us in upholding the value of free speech. Now for our guests. Matt Vallière is the Executive Director of the Patients' Rights Action Fund, a national, secular, nonpartisan, and nonprofit organization that seeks to defend the rights of patients, people with disabilities, our elders, and the poor from the threat of legalized assisted suicide. He has owned and managed various private businesses and worked both professionally and voluntarily for nonprofit causes, most currently with PRAF since 2014. He has been published in media outlets such as the New York Times, Washington Post, The Hill, Real Clear Politics, and Newsweek, among others. He also proudly serves as a volunteer emergency medical services first responder. Megan S. Wright is a professor of law, medicine, sociology, and bioethics at the Pennsylvania State University, where her primary research identifies ways that law can be used to promote patient autonomy, especially for patients with cognitive impairments making serious medical decisions. She publishes extensively in law reviews and peer-reviewed journals, and her research has been recognized for excellence by the American Society of Law, Medicine, and Ethics and the Society for Empirical Legal Studies. Professor Wright earned a JD from Yale Law School, a PhD in sociology from the University of Arizona, and a BS in sociology from Brigham Young University, and she obtained postdoctoral training at Weill Cornell Medical College, Yale Law School, and the James E. Rogers College of Law at the University of Arizona. Please join me in welcoming Mr. Vallière and Professor Wright to the Buckley Institute and to Yale. And I'll begin with a quick note on our format today. We'll begin with 5 minutes of opening remarks from each of our guests, starting with Dr. Wright, proceed into 2 minutes of rebuttals from each guest. Then we'll move into 30 minutes of Q&A, where you, the audience, will ask questions. And then we will conclude with 2-minute closing statements. So I'll hand it off to Dr. Wright.
So thank you to the Buckley Institute for hosting this event and for inviting me to participate. I'm looking forward to our discussion today. As mentioned in the introduction, a lot of my legal scholarship attempts to identify ways to promote autonomy for medical and end-of-life decision-making, including for people with disabilities. My comments today build upon my belief that people should not be prevented by law from making private, personal medical decisions in consultation with their doctors, and this includes life-ending decisions. Let me open by describing the legal landscape in the United States of what is called physician-assisted suicide, or medical aid in dying, or death with dignity. This is one of those topics for which the language you use tends to reveal your position on it. For me, in my academic work, I use medical aid in dying because this is a commonly accepted term in the scholarly space, but I personally am indifferent to the language that we use. My preference would be to debate the policy itself and the implementation thereof. So medical aid in dying is legal in 11 US jurisdictions. Oregon was the first state to legalize this in the mid-1990s, and it has become legal, or at least not criminalized, via voter ballot initiative, state legislative activity, or court decisions over the past 30 years. As the description of this event notes, lots of voters and state legislatures are discussing right now whether to legalize it or prohibit it. So this is a very timely discussion. Although there's procedural and eligibility variation by state in the United States, generally, medical aid in dying is going to be available to terminally ill adults who are legally competent and voluntarily choose to self-administer a prescribed drug that will cause them to die. Being able to control the time and manner of their death is a reason for seeking medical aid in dying. And there's a written request from the patient that's required and a statutorily mandated waiting period between the request and receiving the prescription. At least 2 healthcare providers have to attest that these eligibility and procedural requirements are met before prescribing the life-ending medication. Individuals hastening death in this manner and healthcare providers participating in the process are all doing so voluntarily. No one is forced to participate. It's also important to note that euthanasia, or clinician-administered medical aid in dying, is not legal in the United States, although it is an option in other jurisdictions with medical aid in dying, such as Canada. Americans support legal medical aid in dying. According to recent Gallup polling in 2024, Americans support legal euthanasia, 70%, and physician-assisted suicide, 66%. Now, there is a gap between support for legalization and thinking that this is a morally acceptable way to die. Only a bare majority of Americans think that this is morally acceptable. So based on that polling, it's clear that Americans think medical aid in dying should be a legal option, even if they don't think it's morally acceptable, and even if they themselves would not use it. Indeed, despite medical aid in dying being an option in 11 jurisdictions in the United States over a lengthy period of time, very few people actually use it. Well under 1% of deaths are due to medical aid in dying in the jurisdictions where it's legal. If you look at California, the most populous state that has access to this end-of-life option, in 2023, only 0.3% of deaths were with medical assistance. Generally, the people who use this option are white, educated, and have health insurance, groups that we don't typically think of as vulnerable. So let me now move to my normative point. Over the past few decades, we've been debating the law and ethics of medical aid in dying. We are not going to be able to obtain agreement on whether it is moral or not. Indeed, if you look at physicians and healthcare providers and their professional organizations, they're still debating whether it's consistent with medical ethics, and there's not consensus on that. But let me offer a guiding principle that may make policy agreement more likely, and which is consistent with public opinion about medical aid in dying. As we live in a pluralistic society with a diversity of values, beliefs, interests, and views, we can maximize welfare by promoting individuals' freedom to pursue their conception of the good life, and in this case, the good death, subject to some constraints. I submit that competent individuals should be able to make private, personal decisions free from restraint insofar as these decisions do not harm others. This holds even if others find that person's decision to be immoral or in conflict with their deeply held values and beliefs, or even if that other person's decision causes them to die. Under this principle, medical aid in dying, as regulated in the United States, should be an option for individuals who desire it for whatever reason, even if others would not make the same choice and would in fact judge that choice to be immoral. Because medical aid in dying would continue to be voluntary, individual autonomy at the end of life would be respected, regardless of whether someone chooses to hasten death or not, and thus well-being and overall welfare would increase. Thank you.
Thanks very much for having me. First, this is not a very easy conversation to have. It could be a trigger for some people. Suicidal thoughts or actions, even in adults and people with disabilities, are a sign of extreme danger and should not be ignored. Please, if you or someone you know need immediate help, please call or text the National Suicide Prevention Lifeline at 988. For my friends in the disability community, I am a early 40s man of color with olive complexion, dark wavy hair, short cropped dark beard. I've got a blue suit on with a white shirt and a pink tie. I'm the executive director of the Patients' Rights Action Fund. We take no position on the moral or ethical implications of somebody taking their own life, while opposing assisted suicide laws. Today, I represent an extremely diverse coalition that spans the worldview and political spectra. Right, left, secular, religious, all hold hands walking into state houses to oppose assisted suicide laws. Why? Assisted suicide and euthanasia laws are dangerous and discriminatory. Given the many barriers to access to care people face, a broken healthcare system, the fact that not everyone has a nice family, that coercion always happens behind closed doors, the nebulous definition of terminal under these laws, and the less than exact science of prognostication, assisted suicide laws cause far more harm than the supposed good. To substantiate that claim, let's examine what these laws do legally. First, they convert suicide into a medical treatment under the law. Secondly, they provide criminal, civil, and professional liability immunity to the medical professionals participating in another person's suicide. Normally, those people would be protected from bad actors in that way. Okay? Full stop. They don't do anything specifically in the law for patients. There's no state in America that criminalizes suicide. Okay? Why is this a problem as a public policy? Because tough cases make bad law. First, all the safeguards in these laws are circumventable. If one doctor says no, you just doctor shop until you find one that says yes. Pro-organizations in legal states, in some places, they claim up to facilitating up to 95% of the assisted suicides in their state. So they're referring people who call in to an easy yes doctor. Okay? If a doctor bends the rules a little, so what? There's no meaningful reporting, oversight, or investigation. Even if there were, remember that legal immunity. All they have to do is claim that they were acting in, quote, good faith, and they're off the hook. Everything else a doctor does in this country is held to the negligence standard. Okay, that's up here. With 1,000 times the therapeutic dose of morphine walking out of a pharmacy under these laws, you would think that we would hold these people to a higher standard. Just this week, there was a British man who was diagnosed with ALS, went to a specialist, the diagnosis was confirmed. He signed up for euthanasia in Switzerland. Come to find out, the dude doesn't even have ALS. Never mind the prognosis being incorrect. If you legalize this stuff, there will be mistakes in prognostication. People will lose years and sometimes decades of their life over a best guess. And of course, this is 6 months to live with or without treatment. So, a patient can opt to forego care, even food and water, in order to qualify, thereby obliterating this supposed safeguard. Treatable illnesses like diabetes, a hernia, HIV, anorexia, to name a few. And yes, some doctors in the United States of America and in other jurisdictions that have legalized in this world are helping people with anorexia to kill themselves. So, look, both for-profit and government insurers have denied coverage for life-saving and life-extending care while covering assisted suicide laws. When assisted suicide is on the books, there are perverse incentives for greedy insurers and budget-starved bureaucracies to make it easy and accessible, all while cutting coverage and the social safety nets that make it possible for many people to live meaningful lives. Many people face barriers to access, family and financial pressure. You know, all of these things are in the, you know, it's been shown that where assisted suicide is legal, non-assisted suicide rates go up. Supposed safeguards or limits in place at the outset are always decried as barriers to access just a few years later. You know, so look, in our less than utopian world, there will be mistakes, abuse, and coercion. Public policy is just that. It needs to take into account how this will impact everybody in the public.
Now for a brief rebuttal from Dr. Wright.
So thank you. I want to focus a little bit on the issue of safeguards, abuse, mistake, coercion. So there is no perfect system. We can't design it. Nothing that we have under law and regulation is perfect, but we can implement safeguards meant to achieve our desired goal. In this case, autonomy in end-of-life decision-making. So in order to ensure that the decision to hasten death is autonomous, the safeguards that we currently have in the United States include things like the terminal illness requirement, and that is defined by statute. So for example, in California, that means an incurable and irreversible disease that has been medically confirmed and will, within reasonable medical judgment, result in death within 6 months. So a lot of people tend to focus on the death within 6 months and forget that it's the incurable and irreversible. So it's been asserted that someone could basically voluntarily stop eating and drinking, put themselves in a terminal condition and qualify, but that actually would not qualify under the statute because that is reversible. They would just be rehydrated and receive nutrition and no longer be terminally ill if they didn't have another sort of illness. We also have other safeguards, like capacity. You have to have decisional capacity at the time the requests are made in order to use this. We have the self-administration requirement. The person themselves has to administer the life-ending medication. We have an extensive informed consent process that's required by statute. Multiple physicians are involved. People can actually approach their doctors about this and be diverted into palliative care. Maybe that better meets their needs, but they didn't know it was an option or didn't know how to get connected with it. So this is actually the most regulated way to die in the US. There are lots of other things that happen behind closed doors that don't have this level of oversight by the state, like withholding or withdrawing treatment or palliative sedation or voluntary stopping eating and drinking. This might actually be the safest way to ensure autonomous decision-making at the end of life. And I will stop there.
The idea that somebody's actually looking over the back of these doctors and determining whether or not somebody is making an autonomous, fully aware decision is a farce. At the time of death, at the time of ingestion, there is no third-party witness. As soon as those drugs walk out of the pharmacy, it could be 5 months later the person takes the drugs or a year later. There is zero oversight when those drugs walk out of the pharmacy. So the idea that somebody's actually self-ingesting, taking that of their own accord, a tired caregiver or a greedy heir could easily have the cover for the perfect crime in this situation. I just want to read you a quick note to end. This is a quote from a young woman with anorexia in Colorado who was prescribed lethal drugs under these laws. I was told that although I wasn't yet 30 years old at the time, my doctor would make an exception for me and allow me to die if that was my choice. It didn't feel like my choice. I felt coerced. I'm not sure how to describe it, but something inside me wouldn't let me take the maid. You're dealing with supposedly irreversible and irremediable conditions in the US, but in fact, if somebody can opt to forego care as a patient and qualify for lethal drugs, which there are documented cases of this happening, where somebody can stop eating and drinking. In all due respect, there's a documented case by proponents of assisted suicide laws where somebody used that means to qualify for lethal drugs. She had no terminal illness. She had a dementia diagnosis where she didn't even have actual symptoms of the dementia. We're talking about a fast and loose set of public policies that actually has no oversight. In fact, the Health Department of Oregon is quoted as saying, we have no funding or authority to do any oversight on these laws. They're just too dangerous for a public policy. And that's to say nothing about a person's individual choice in the matter of their end-of-life decision-making. We're talking about medical professionals helping somebody to die.
Thank you to both of you. We'll be moving into a period of audience Q&A. Please raise your hand if you have a question, and I will come to you. No takers yet. Back here.
Hi. Hi. It seems to me that one of the biggest issues sort of situationally with assisted suicide, especially in the United States, is the way that our healthcare system is set up. It seems that there's, in some ways, a perverse incentive to administer life-ending care if it were allowed. And so I'm curious how each of you reckons with the structure of our healthcare system and how that plays into a moral issue when healthcare is treated as an economic one in many cases in our country.
I can go first if you want. So, look, I'm not suggesting that proponents of assisted suicide laws do the brutal utilitarian calculus of determining that, in fact, this is going to be a pressure relief valve for an overburdened system. But that is the net effect of legalizing assisted suicide. And in fact, the state of California passed assisted suicide in a special session dedicated to coming up with a $1 billion shortfall in their Medicaid program. you can't do any laws in the special session that are non-germane to the session. They passed the law in order to save money, ostensibly. The Canadian single-payer system, look, like, whether you think single-payer is better, whether you think this broken for-profit system is better, that doesn't matter. In fact, look, like, I have no misgivings about our broken profit-driven healthcare system. I think it's terrible, right? But the single-payer system does no better. Why? Because they're all budget-starved too. So you end up in a situation where the Canadian government literally took a look at how much money they would save, which was $150 million when they legalized euthanasia. And that was back then when, although here in the States the thing hasn't taken off, in Canada, because they have a more federalized system and everything just goes straight from the federal government, you ended up with a system that got swept away. And now you have over 5% of all deaths in Canada being hastened deaths. And in some provinces, you're up to 8%. And like it boggles your mind. They're killing people at this. They all start where we start, with the supposedly terminal illness thing. And then none of these laws get tighter. None of them get more careful. None of them are figuring like, oh, well, maybe we should also cover palliative care, guarantee home care, guarantee long-term services and supports, while at the same time providing this. None of them ever say that. They all say, okay, well, look, like, we're drowning. We can't figure this out. And yeah, and here's assisted suicide too. Okay, so in a world that is imperfect, it seems to me that even if you don't have the brutal utilitarians driving this truly, that is the net effect. So you end up with a system that devalues some people to death. And generally speaking, they're the ones who are devalued in society. So now you have people who are literally applying for euthanasia in Canada because of grinding poverty, and they're getting approved. You have veterans calling in with PTSD, and euthanasia is suggested to them. You have people who are on Social Security disability, cannot afford accessible housing for their disability in Canada. They apply for euthanasia and are approved because they don't want to be homeless. This is what it comes to. I'm sorry, but this is not a slippery slope. This baby was off the tracks before it started down.
Okay, so I do want to highlight a point of agreement. I do think our healthcare system in the United States could be reformed to have more affordable healthcare and more access to it, especially for people with disabilities. I don't think we're in disagreement about that. I do want to note that I think it's possible to both design a healthcare system that is affordable and accessible and also have medical aid in dying as an end-of-life option. I don't think it's an either or. Looking also just at the United States, I'll focus on California for a minute. Medi-Cal is the Medicaid program in California. That's for low-income people. You can't go above a certain income threshold in order to have health insurance through Medicaid. But when you look at the statistics of who uses the California End-of-Life Option Act, it's like single digits of people who are on Medicaid. So if we think that people who are impoverished are being forced in medically and dying, we are not seeing that borne out in the statistics in the United States. I'm not as familiar with the Canadian context. I don't do Canadian law.
Further questions?
So, this question is for a gentleman. Hi, this question is for you. So a lot of your points were based on the fact that our law is imperfect and that there can be people who abuse the system. But what if, say, like, we implement the law more strictly and that we theoretically say we are in a perfect system and that no one can abuse this, then would you change your argument? Like, would there be any other grounds for maybe, say, moral implications of using euthanasia that's beyond just practically we can't really implement this?
So, look, if we lived in utopia, where everyone has a nice family, everyone has perfectly equal access to the best gold standard of care, et cetera, et cetera, et cetera, like, I still don't think that assisted suicide laws work. Why? Okay, so under assisted suicide law, you have to be X, Y, or Z in order to qualify. What that really means is that when you enter a healthcare setting, you express the desire to harm or kill yourself. I'm a first responder, volunteer in my town. I go to calls where people threaten or attempt suicide regularly. We have a standard of care. The standard of care is you express the desire to harm or kill yourself. I do everything I can to stop you from doing that. That is the standard of care. It should be the standard of care for everybody. But it's not the standard of care for people in states where assisted suicide is legal. Why? It's the standard of care for some people, but for others, not. And who are those others? Those others are people with life-threatening disabilities in the US currently, for the moment. These laws never get tighter. They never get more careful. There's never more and better reporting. There's never more oversight. It always just becomes more and more people included in the bucket of those who don't get the standard of suicide prevention care. Who are those people? In the US, it's people with life-threatening disability. And that could be anything from stage 4 metastatic cancer all the way through to, I'm really depressed, I have diabetes, I'm off my insulin, therefore I qualify. Or this lady who had a dementia diagnosis, no symptoms. I'm voluntarily stopping eating and drinking. Now I qualify, doctor, give me the drugs. Doctor gave her the drugs. Okay, so who are these people? If you look at the qualifications in the letter of the law, never mind how people interpret it, and never mind how they might be interpreting it and breaking the law, but there's never any implication for them because they're acting in good faith. So let's just take the letter of the law for a moment. The letter of the law would say, in the US, 6 months or less to live. All of those people, whether it's the person with stage 4 metastatic cancer or the young woman with anorexia, all of those people are ADA-defined people with disabilities. Every single one. They all have a condition that limits some major life function. And so what you've done is you created a subset of people for whom the standard of care does not apply. And those people happen to be a protected class. And so therefore, you've treated a protected class in a different way than you've treated everybody else. It'd be like saying, okay, look, we all come into a medical setting, and anyone who looks like a man of Middle Eastern descent, if they express a desire to harm or kill themselves, they get suicide help. Everybody else gets suicide prevention. That's discrimination. You simply cannot set aside a group of people for whom suicide prevention standards don't apply. And in every other jurisdiction, we never say okay, suicide for all. We always say, well, it's for this group of people. And then when they expand, it's for this other group of people. All those groups of people are additional subsets of people with disabilities. We're never adding, perfectly healthy 20-year-old, women. We don't add that group, right? Why? Because you are valued in society. People for whom a suicide prevention standard doesn't apply are devalued in society. And for most of the people in this room, coming from a privileged circumstance, you don't know what it's like to walk into a medical setting and be treated different. You don't know what it's like to be denied coverage for care. You've always gotten the best standard of care, probably. Let's just be honest with ourselves. I'm no different. I came from that same situation. But as a matter of fact, some people do experience that in this country. Some people don't have equal access to the best standard of care. And when you are devalued by medicine, I'm talking 80% of doctors think life with a disability is less worth living, according to a recent Harvard study. 80. The majority of them don't even think that they're capable of taking people with disabilities into their practice. If you're fighting against a system that already sees your life as less worth living, how do you expect that these people already demoralized by a system stacked against them where they're getting denials and doctors that don't want to treat them and all this stuff, that in itself is a kind of pressure. And so the utopia world that you're thinking of, I would love to live in it. But we don't.
More questions?
My question's kind of a follow-up to this one. So let's say that, like, for these areas in which medically assisted suicide is legal, how can we make it better? Like, how can we prevent it for these cases where it's like the doctors coercing patients? How can we prevent these cases in which maybe it's not the best option? So, like, what regulations can we have in place? I know there was some talk about, like, how, you know, we need, like, multiple doctors to approve this, and we need the patient's consent. Is there more checks that we can have in place? And what are the standards that maybe we should have for our healthcare providers?
So I will take that and say that we have a legal regime where states have laws that you can go and read, and they outline a minimal process. But we have a sub-legal level of regulation, and that's organizations and organizations' policies. So like hospice organizations, hospitals. Also you have the medical standards of care, so professional ethics and professional practice. Oftentimes these policies, they are not laws, are actually stricter than the laws on the books. So let me give you an example of the University of California, San Francisco Medical Center. Their patients have to go through a really extensive process before any of the doctors will prescribe the life-ending medication. So they have a 100% capacity assessment. So everyone has to go through it. There are referrals to social workers are involved. And so you have lots of people checking to see whether this is in fact an autonomous choice, separate from is the person terminally ill and so forth. And there's some other things that really make the requirements stricter for patients at this site. So we have this other level of regulation, organizational policy, medical ethics, and so forth. I also just want to note very quickly, it is not quite true to say that we always are going towards loosening with our laws. States do vary over time. They are different from each other in their regimes. When Hawaii first passed medical aid in dying, they had a 21-day waiting period rather than 14. They've since made that shorter. But so that would be an example of saying we need a much longer cooling off period here than 2 weeks. We're going to give you 3 weeks to really think about it and make sure it's an autonomous choice.
I mean, isn't that very point itself showing that the cooling off period got shorter? And as a matter of fact, in all of the states that have legalized, they're all attempting to shorten the waiting period?
So there's a reason for that. So one of the reasons why, when Oregon first passed this as the very first state, they wanted to make sure that they weren't having everyone just come and kill themselves in Oregon. So they designed a system where very few people were actually going to qualify. And one of the reasons, you can say it's an autonomy reason, this 2-week waiting period, like a cooling off period with really thinking about it, consulting with your physician and so forth. But let's go back to our terminal illness requirement. You have to be terminally ill to even get the first conversation going with your healthcare providers that this is going to be a serious option. What was happening is that these people were so sick and so close to death that they were dying between point 1 in time and point 2 in time. They were dying within that 2-week waiting period of their underlying illness, not of assisted suicide. So states have looked at that and said, well, this is actually not autonomy promoting if we're making people really sick, very close to death people, wait this long that they're dying before they can fulfill the statutory requirements.
I mean, it just seems to me that when you shorten the period, you've just removed one of what was proposed by proponents themselves as a key safeguard so that people aren't making rash decisions. People who desire suicide, they're not like, most people don't want to die, whether they want assisted suicide or they're trying to kill themselves in other ways. It's an ambivalent situation. And so for somebody to persist for that long, I mean, look, like, if we're really going to your question, balance this somehow, what can we do to make it more this or that? You have to look at, okay, well, look, like, it's not going to apply to everybody. And if it doesn't apply to you, that's unfortunate for you if you thought that was somehow a good for you. But as a matter of fact, that there's all kinds of restrictions within these assisted suicide laws that do exclude groups of people. And they're supposedly excluding those groups of people in order to protect vulnerable people from mistakes, abuse, and coercion. Now, what could be possible ways to make these laws better? You know, I don't like to use the crass turns of phrase that would immediately come to mind, but you can't polish something that's intrinsically bad. Okay, so Yeah, I'm just going to leave it there. But if you were going to make something, like, say, the worst, better, it's still bad, but you could make it better. And there are ways to make it better. Things like even as simple as third-party witness at the time of ingestion to ensure that the person actually took it themselves and that they actually wanted to do it. You know, California itself, they removed the final attestation, which was a written, yes, I'm doing this of my own accord. They removed that from the law in a recent amendment. It's like this doesn't seem to be promoting autonomy in any way. Right? Similarly, you have very little reporting that is actually exposed to the public. The doctors are the participating doctors are the only ones who report back to the state. The state has no funding or authority to review problem cases. Like if there's a red flag, there's no ombudsman. There's nothing to fall back on for somebody to actually enforce the law, which is why there may be some people acting outside of the law and like kind of bending the rules, but there's never any enforcement of those rules. The doctor can just simply claim, I was acting in good faith, and they're off the hook. So now what do? Well, we actually enforce the rules. You set in place something in state government that oversees all of these things. You have a hotline to make sure that if there are problem cases, that they're investigated. You have an ombudsman to call if something goes wrong. You have third-party witnesses. You have third-party reporting. Not the participating doctors. If you're breaking the law, you're going to tell the state? No. Right? So let's be honest about what looks like a safeguard and what's really just smoke and mirrors. If you really wanted to protect vulnerable people, you would be doing things that are non-circumventable. Like if one doctor says no, why is it that the next doctor with zero implication can say yes without ever consulting the first doctor, without there being a state authority for the two of them to submit their cases to and say, look, like I think this person doesn't qualify. Well, I think they do. Here's who's going to adjudicate that? Nobody currently. Like, these are all like serious problems with a law that means life and death. But I don't think that you ever really get around the problem, at least in the US proposals, of the prognostication. I don't think you ever get around the problem of inherently discriminatory public policy. So if you want to make something that's dangerous less dangerous, it's like every car goes 100 miles an hour at all times. Like, well, let's put a regulator on it, makes it go 90. Okay, that's maybe what you could do, but in the end, they're just too dangerous for the public.
Further questions? Pass this down. So my question is primarily for Dr. Wright. We've had some discussion of different safeguards, and it seems like most of these safeguards can kind of be put in the category of autonomy and consent. But then we have this additional safeguard that seems somewhat less related to autonomy and consent, which is the requirement that people be terminally ill or that they be within 6 months of death. If we believe it appropriate for physicians to assist people that have autonomously expressed an intent to die, why do we draw that distinction of the 6 months or of terminal illness, and why, like, how do we set that arbitrarily at whatever time period it may be?
So this is a great question, and it gets at something that's come up a little bit more through these remarks, which is a conflation of suicide and physician-assisted suicide as regulated in the United States. In the United States, there seems to be some agreement that when one is facing death, imminent, foreseeable, natural death, that it might be rational for that person under some circumstances, as they define it themselves in consultation with their physicians, to hasten their death. As distinct from someone who is using this phrase suicidal or expressing an intent to harm or kill themselves, usually extreme emotional distress, maybe the effects of traumatic brain injury or mental illness. We have different bodies of law that address that. In the case of suicidality at large, we are looking at public health, safety, and welfare, and the state's duty to save lives. In this other space, in facing terminal illness, we're looking at people's right to bodily integrity, bodily autonomy, making private personal medical decisions with their doctors. So these actually are distinct. I will also note that in the United States, if you have a ban on assisted suicide in your state, you're saving no lives because these terminally ill people are going to die of their underlying illness.
Thank you both for your time. This is for Dr. Wright. In your overview, you talked about 70% of America supports it, while 50% of America is like morally for it. The last Buckley Institute talk I went to was a church and state talk. Could you talk more about the underlying, like, are there certain religious groups against this? And like, do you think it's like a right of individualism, or what's driving the 20% gap?
So I am not an expert on religion, and I cannot tell you the various religious groups' perspectives on physician-assisted suicide. So I am going to sidestep that. But I will say that we do see differences. So I gave you the large statistics looking at America as a whole, but we actually do see differences in support by where you live, education level, political affiliation, and religiosity. So if you say, when we look at levels of support, those who say that they're more religious have lower support for medically assisted dying. Higher education, that tends to translate into more support. Being affiliated with the Democratic Party tends to be more support. But what I find most interesting is where you're from in the country. So if you're from the West, you tend to support this. If you're from the Southeast, no support. And if you look at the Midwest, it's a little bit of an outlier because there's high levels of support in the Midwest, even though not a single state there has this as a legal option. So we do see breakdowns by that. About the religion question, I cannot answer that.
More questions?
Thank you. My question is for the gentleman. You did a great job of pointing out the flaws in the system, and in one of the answers, you also talked about how those flaws could be fixed. I just find it curious, why are you lobbying to ban this rather than lobbying to fix those flaws? Because I think, or maybe I might be wrong, but from your initial statements, I got the feeling that you do agree that there might not be, that some people might need it, but it is being abused, and people who don't need it and should, try to get better and like improve their lives are abusing the system. So I just want to understand, why are you for banning it rather than for fixing it?
So as I mentioned earlier, it seems to me that there is no circumstance under which I would say assisted suicide laws have more of a good than they do a harm. And in public policy, you have to take a look at how this is going to impact everybody. Now, I speak for an organization. We take no position on whether somebody has a morally ethical implication about taking their own life. Okay, so now as a side, if you look at what we're talking about as a public policy, now all of a sudden it's like, okay, so who does this help? Who does this harm? I don't claim that it helps anybody. And personally, I don't think it does. If you're suffering at the actual end of your life, you need a new doctor. Medical science, palliative care has come so far in this country that in fact, if you are in physical pain, suffering at the end of life, you should get a different doctor because they're not helping you adequately. There are ways of alleviating your physical pain at the end of life. Now let's take a look at the reasons why people are requesting assisted suicide in legal states. Physical pain doesn't even hit the top 5. The top 5 reasons people are requesting lethal drugs in legal states are all disability concerns. They are. I'm afraid of losing my dignity. I'm afraid of losing my autonomy. I'm afraid of losing the ability to control my bodily functions. I'm afraid of losing the ability to do the things I used to enjoy. And I'm afraid of being a burden on my family. When some proponents get up and they talk about, like, what does that mean to lose your dignity? They're like, oh, well, I can't use the bathroom by myself anymore. That's when I want out. It's like, how many millions of Americans need help going to the bathroom every single day? And you're telling me that we need to tell them in subtle terms that they too live an undignified human being life. They wouldn't think so. But that's the message you send. You send, like, this disability is a fate worse than death. Therefore, this person is going to choose death. Now, if you choose death, I, as your friend, as a fellow human being, I'm going to do what I can to stop you, but this is your individual choice. you can't legislate morality or something like this. You can't legislate what I think is your good, okay? We're not going to make fines for people lying, right? But at the same token, we're also not going to have doctors become Pez dispensers. Like if I say, okay, doc, look, I'm going to express my autonomy and I really want you to cut my legs off. Can you find one doctor in America that's going to cut my legs off? No. Because that's heinous. Right? Because we don't do those things. That's a harm to the patient. Okay, so even if the person may be desirous of this thing, does it mean that it's a good for society to have a law that provides legal, civil, professional, and criminal liability for a certain set of people when they help that person to kill themselves? There's no laws like preventing somebody from killing themselves. Okay, so you can do this if you want to. There seems to be no lack of means. Suicide is an absolute epidemic in this country. We're in a crisis, by the way, of suicide. If lethal means was the problem, I don't know how to talk to you. But if we're talking about somebody being able to express their autonomy in that way, I don't know how to talk to you. But if we're talking about somebody else helping them, if you said to me, Matt, I really want to kill myself, I'd be like, dude, whoa, let's talk about this. I'm not going to hand you a pistol. If I did, guess what? You kill yourself, I go to jail. Why is it that, and similarly, if you had stage 4 metastatic cancer, you're dying in 2 weeks, I hand you a pistol, I still go to jail? Why? Why, if the rationale is this person's dying anyway? That's a question we don't wrestle with about this issue. Okay, so if you're, okay, so, we need doctors involved because they need to determine that there's definitely only 2 weeks left. Okay, well, just get the doctor's paperwork. So now I can hand you the pistol? Where's the threshold? What are we talking about here? We're talking about one person helping another person kill themselves. Every state in America has a criminal penalty for helping another person to kill themselves. Why is this the case? Ask yourself. It's because people who want to kill themselves, generally speaking, are vulnerable, and whether or not they have a life-threatening disability. And so we do what we can as a society to protect them, both from themselves and others, from undue influence. Look, I don't see a way to do these laws that would protect vulnerable people from the mistakes, abuse, and coercion. And I just can't wrap my mind around the idea that there would be some casualties that are acceptable in this. There are going to be mistakes, abuse, and coercion, as was admitted. So if we're going to have some flaws, how can we have a law on the books that hurts this, that puts a great number of people under pressure and risks the lives of some people through mistakes, abuse, and coercion, so that this supposedly infinitesimally small number of people have one more means to an end to which they already have access?
Thanks. So I'm assuming that these laws are for people who are not in a position to commit suicide themselves. So I don't see the point of making an argument that people are committing suicides. I'm assuming that this is for people, for example, you're not able to control your body at all, and you're not in a position to do it yourself.
Your assumption is deadly wrong.
So why not, again, coming back to my point, why not fix the law that this can be provided to only those patients who are not in the position to do this themselves? That's what I'm trying to get at. Why not try to fix the law rather than try to ban it completely? I get all of your other points that people who are vulnerable might be making a bad decision because they are in a vulnerable place, but people who are in a place where they just can't do anything themselves, why not do this for them?
Those people wouldn't qualify under assisted suicide laws in the first place because they have to self-administer.
Which is a form of disability discrimination, don't you think?
In presuming that assisted suicide isn't itself fundamentally disability discrimination.
Is there some sort of statistic for people that are like misdiagnosed and told, like, for example, and this is a real life example. My mother-in-law was given 6 months to live. She decided to fight. She had cancer at one time. She decided to fight it, get treatment. She lived 35 more years. And then, you know, if there was a law at the time and the person was maybe counseled, well, you got 6 months more to live. We can maybe do treatment, and then you'll die anyways, or, you know, you have a 5% chance of living or whatever. And then they would have given counseling to, well, maybe we can assist you and to have a dignified death within 6 months or whatever. I think that for me, if you had a statistic as to how many people are misdiagnosed, obviously there's some people that you know that they are going to die because of medical reason, but there are a lot of people I think that are misdiagnosed, because I've heard of other cases like that in real life, that people are diagnosed with a very short time to live and they decide to fight and they get treatment and they live 10 or 15 times more than what they gave them to live.
Yeah, so I'm no like medical statistician, but as far as I understand the medical literature, at the 6 month mark, physicians are actually more often wrong than they are right about prognosis. Once you get really close in, say like 2 weeks or something, they're almost always right. So, look, like I don't have that stat right off the top of the head, but it is out there to look at, like, you know, it's not specifically with request to assisted suicide. It's just like at the 6 month mark, how often are doctors correct? How often do they miss the mark? And then, you know, how many people might have died if they were misdiagnosed? Unknown. But I think it's worthy of note how inaccurate prognostication is as a science. It's meant to be a best guess. The 6 month mark was put in place in 1982 by Congress in order to save money under hospice. So the hospice benefit became paid for by Medicare in 1982 because of a budget study that showed that at that threshold, that's where they'd save money. You know, so then the assisted suicide folks grab that and use it because it's kind of, you know, common knowledge parlance, you know, people facing the end of life, they, 6 months, that's when you're terminal. But as a matter of fact, like, people can be terminal at, you have a terminal disease like ALS, nobody gets out alive. Like, you could have 2 months, you could have 5 years, nobody knows for your particular case. But you're gonna die from it. We don't have a cure yet. It doesn't mean that there won't be a cure in the next 5 years, but those are the sorts of things that, whereas something like, you know, anorexia, there's no good way to determine whether or not this person is terminal, and yet doctors around the world are prescribing lethal drugs to people with eating disorders. 60 known cases worldwide. It's unclear in terms of your question, like the exact number, but look, like these are problems with these laws.
Can I have 20 seconds to briefly respond? Okay, so I don't have those numbers in front of me, but because, as he stated, this is tied to a hospice Medicare benefit, which is the 6 month period of time, you can actually, there are studies published in medical journals showing once someone qualifies for the hospice Medicare benefit, how much longer they're alive. So sometimes it is much longer than 6 months. So we actually do have the information out there, I just don't have it in front of me.
I think it's 12% actually graduate from hospice.
Yeah, so some people get it and they live longer than their benefit, and they continue their benefit, or they might leave if they end up with a treatment that works. So there is information, statistics out there about that.
And some people go off and on, and you know.
And then very briefly about the anorexia issue, there is an emerging sort of evolving discussion among psychiatrists about whether in some cases anorexia in particular, out of all the mental health conditions, is going to be a terminal condition for some subset of patients. So it was not thought of as necessarily terminal, but we now do have instances of people with such severe anorexia that is treatment resistant, meaning they've tried treatment multiple times, that these individuals are going into hospice and palliative care. Young, because anorexia tends to be a disease towards young women and some subsets of young men, but that's evolving about whether or not that actually is a terminal condition.
Yep, thank you both for your comments and for everyone for their questions. And we'll just close with 2 minutes of opening statements from each of you, starting with Mr. Vallière.
So look, we've had a robust discussion today. I'm grateful for all your time. Assisted suicide laws as proposed in the US, or really anywhere else, are a public policy that puts a great number of people under pressure and risk of deadly harm while providing an additional means to a privileged few who already have a range of options available to them, including high-level multidisciplinary palliative and hospice care. In this country, we pride ourselves on being the ones who take care of the least fortunate. But are we really? Or are we just giving them the shaft? Are we just saying, look, you're not worthy of health care, worthy of health care dollars, worthy of my time? We've filed a lawsuit in the state of California to overturn the assisted suicide law there based on the ADA, Americans with Disabilities Act. One of the plaintiffs in that lawsuit, black man from underprivileged circumstances, bilateral amputee, two-time cancer survivor. He just passed away from his third bout with cancer. This guy's a quadriplegic from a gunshot wound. He felt like he was approved for home care, but couldn't get it because there wasn't enough providers in his area. He felt like such a burden on his family that he decided to go seek assisted suicide laws, to seek death through these laws. He would qualify based on his disability. He ended up in an emergent situation, got rushed to the ER. The ER doctor said, look, we don't want to participate in that, but if you want to kill yourself, we'll admit you to the hospital and we'll palliate you until you die of starvation. If any of you did that, they would chain you to the bed and make you eat. They would do everything in their possibility to keep you from killing yourself. But him, not so much. For him, his suicide was rational. His 30-year PCP came to the rescue and said, Lonnie, don't do this thing. And he came back from the brink, got home, got decent care, and thrived for another several years. This is the problem with assisted suicide laws. They are, as the American Medical Association says, impossible to control. I'll leave it there.
So we could have been having this same discussion about medical aid in dying 30 years ago, because the underlying moral debate has not changed. What has changed is that we have no evidence for some of the reasons offered in opposition to medical aid in dying. People are not being forced to die when this is a legal option. Indeed, that is one of the strongest counterarguments for saying that we should not have this as a legal option, that individuals are going to be forced to use it to end their lives, including vulnerable people, including people who are impoverished or people with disabilities. But it is not obvious that caring about the lives and well-being of these populations means denying them, or an entire population of people, choice about the end of life. Instead, we should more appropriately target our recommendations and proposals to address the stated concerns with legal medical aid in dying. If we care about lack of access to affordable healthcare for people with disabilities, the proper target is not banning medical aid in dying, but rather reforming healthcare. We can also focus on reducing poverty to ensure people have fewer constraints on their autonomy. Indeed, it is possible to have both good, affordable healthcare and access to medical aid in dying. Further, in the United States, medical aid in dying is designed with multiple eligibility and procedural safeguards, so the risk of non-autonomous use is minimal. We have no reliable evidence, despite 30 years of access in at least one state, that people are being forced to die. This suggests our safeguards are working. Now the debate, which we've not really talked about, but is a debate, is whether there's sufficient access to this end-of-life option, or whether the existing safeguards are functioning as barriers, creating unjustifiable disparities in end-of-life options. In brief, in the United States, we have ensured that medical aid in dying is an option and not a mandate. So if disagreement about legality remains, we're not disagreeing about safeguards to prevent coercion, but instead we're disagreeing about whether medical aid in dying can ever be a moral choice. And when it comes to moral disagreements in which an individual's decisions do not harm others, we shouldn't interfere with their medical and end-of-life decision-making.
And with that, could you please join me in giving a warm thank you to our guests?